What are the cases like, as you said, still umbilical cord, and is it common?
Fibroids can grow huge, big sizes also. So it depends upon the presentation of the patient will not just matter which part of
Is it the one common factor for bleeding too much? Like,
the presence of the fibroid itself.
how risk is it? Like, during pregnancy, they'll have many myths. Like, during pregnancy, fibroids will grow with pregnancy.
So pregnancy and fibroid, let me come first thing.
Okay.
Not all fibroids will give you.
Heavy bleeding only because of uterine fibroids.
No, heavy bleeding can occur for many other reasons. So in patients with fibroid,
No hype, no fear, just honest health conversations. Hi, I'm Dr. Manasa Reddy. Today we have Dr. Rooma Sinha garu, Senior Consultant Gynecologist, Laparoscopic and Robotic Surgeon. Let's welcome her. Hello, Andy.
hi Mansa, thank you
Namaste.
for having me at this lovely podcast.
Truly our pleasure and happy to see you again. How are
Same
you?
here, Mansa.
How are
Such a
you?
bubbly girl.
Thank you. How are you, ma'am?
I'm doing very well.
Yeah.
A bit tired since morning. I had a long operating list, but it's always a pleasure to come and talk to you.
Thank you for considering us. So let's talk about uterine fibroids. Just briefly explain us what is uterine fibroid.
Uterine fibroids actually is a tumor in the uterus. There's no doubt about it. But by and large, it's also a non-cancerous tumor. So that's a good sign. If you look at the number of people that suffer from it, we don't really have a count on that. But out of 10 women, 3 to 4 will have uterine fibroids. And some of them may not even know that they have it because sometimes it's just a silent disease.
Yeah. So how common is it in these days and who are most affected?
Uterine fibroids can be there right from young girls in their early teens or 20s up to postmenopausal women. So reproductive age group, you find them maximum 30 to 40% of women will have fibroid at some point in their time, in their lifetime. So if you look at, as I said, out of 10, 3 to 4 women will suffer from fibroids.
Can uterine fibroids be avoided or prevented?
I wish we could. As a gynecologist and as a scientist, I know that prevention at the moment is difficult because you need to understand why it develops. And then only we can talk about prevention. Now it develops in a very, very simple way I try to explain, and as I explain to my patients, that the cells of the uterus, which are smooth muscle cells, one of them go rogue. That means they become badmash. And then they start multiplying. What gives them the fuel to multiply are our own hormones, estrogen and progesterone. So they start growing as like an abnormal tumor and they become a fibroid. So if we have to know something to genetically manipulate that particular cell which went rogue and started developing a fibroid, maybe we can prevent. But right now, I'm not aware of any method by which we can prevent.
So how do you diagnose it? Like, how do patients come with you? Is it with a severe pain or bleeding?
There are 2 types of patients who come. Number one, who come who are having some symptoms, like you said. They can have pain, they can have heavy bleeding. They may just get diagnosed when they have difficulty in getting pregnant.
Okay.
So infertility could be one of the presenting symptoms. Or they can just come with a lump, which I'm telling you, Mansa, is not very uncommon in my practice because I've been dealing fibroids by 30 years now. I've been practicing in Hyderabad for 30 years this January. So somehow I have a reputation of dealing with large, big, multiple fibroids. I don't know where they search me from. And they come with fibroids up to their umbilicus or even above. So they'll think I'm just gaining weight.
Okay.
And when we palpate, there's a big mass because they are
not aware of it.
They are not aware of it. And that is the sad part of it. And some patients come to us who don't have any symptoms, but went for a regular health checkup and the scan showed there was a fibroid.
Okay.
So these are 2 categories that they present with.
Generally, as you said, what are the cases like, as you said, still umbilical cord, and is it common?
In my practice, not very uncommon, but it may be uncommon in general population. Yes, fibroids can grow huge, big sizes also. So it depends upon the presentation of the patient will not just matter because of the size. It can also matter which part of the uterus the fibroid is. Okay, that's very important to understand.
Location is very important.
Location of the fibroid is important. So if you think this is your uterus, if there is a big fibroid outside, it just grows like a lump. They will only feel if there is a big thing on the tummy and they can feel it.
Okay.
Then the fibroids can be in the wall of the uterus, which can present with one of the symptoms that you said. Or fibroids can be in the cavity, which we diagnose as submucous fibroid.
Okay.
These submucous fibroids, even when they are small, say 2 centimeter, they can cause so much bleeding that the patients present early.
Is it the one common factor for bleeding too much, like, heavy bleeding and all?
The presence of the fibroid itself. But we must also remember that 30% of fibroids can have an additional problem. And that additional problem can be endometriosis or adenomyosis.
Okay.
Now, they affect uterus in a slightly different manner, and I call them as cousins. So sometimes cousins stick together.
Okay.
So 30% fibroids will be with a cousin like adenomyosis. So even if those patients undergo a myomectomy, which may remove the fibroid and save the uterus, they may still continue to have a little bit of bleeding. And then they'll say, oh, I had a surgery, but I'm still bleeding. But that you have to understand is because of the associated adenomyosis. Some patients with fibroids may have severe pain. Normally, fibroids may not cause so much pain. They have another cousin like endometriosis. So they stick together.
Okay.
And then these patients kind of become more complicated to treat because you're dealing with 2 diseases in the same woman.
Just we spoke about the other case just recently you have done. Parents might be having, that too much of societal consciousness and all. What before marriage, if a girl gets treated or having a scar on her tummy, again, it is difficulty for marriage and all.
Yeah.
Do you see that cases? Convincing them is again hard.
Not very uncommon. Young girls, young women can develop fibroids. These days, girls are educated. They are working. They have already understood their symptoms and problems. So they come forward more often than before. But yes, when such girls come, we always have parents coming in and they're concerned. They have concerns of 2-3 reasons. They are first of all concerned that what is going to happen to this uterus? Will there be a problem in childbearing? My simple answer to them is, if there's a large fibroid, that itself may cause a problem.
True.
So removing them will not cause any further problem. So that's one thing to understand. The second thing to understand is, why are you seeking a treatment? In a young patient who is not married, these are the concerns. Seeking treatment could be possibly because she's bleeding more, or there's a big lump, or there's a lot of pain. So we need to relieve that, right? We can't let her suffer. The third is the social aspect. Of course, parents are worried that there is a surgery on the uterus. As I always say, the uterus belongs to the woman. It is in our body, but it belongs to the whole family.
True.
Unfortunately, right? So everybody has a right on that uterus, right?
True.
So everybody needs to know about it. So I have a little different take. I do these surgeries with lot of care, with precision, by taking care by doing robotic surgeries. They are very, very small holes. Patients recover in 1 day, minimal blood loss, and we try and make those scars as invisible as possible. But my suggestion, and through your podcast, I'll try to say to most parents and those girls, that's better to be upfront that you've had such a surgery.
True.
And I also offer them that if you have a prospective person, you can bring them to me and I will also explain.
Okay.
And I do that very often.
Oh.
And explain to them, this is not something which is so bad that has happened. And a lot of women and so many women actually after myomectomy, removal of fibroids, conceive, deliver. We actually have published our own series of patients whom we followed up for 10 years of all the cases that we did for robotic myomectomy. And we found 86% patients conceived and delivered at term. So it's a good sign, right?
Definitely.
And we have published it and it's available on Google. Anybody can see.
How risk is it, like, during pregnancy? They'll have many myths, like, during pregnancy, fibroids will grow with pregnancy, or is it hard to conceive? Any chances of miscarriages?
So pregnancy and fibroid, let me come first thing.
Okay.
Not all fibroids will give you a problem in getting pregnant. So many patients with fibroid conceive. So the first time patients come to me and she has 3-4 centimeter size fibroid, she's wanting to conceive, I never operate. I said, first try.
Okay.
If you get pregnant, great. Second thing that can happen is, in such a patient, she conceives but she has a miscarriage. That's sad. But then I understand that, okay, because of this fibroid, this is possible. But not every patient will have miscarriage. So give them a chance.
Okay.
When they conceive, many of them go through term with no problem. The fibroid is said to grow, but doesn't grow that much. It actually flattens out. Because as the uterus stretches, the fibroids flatten out.
Okay.
It's not that 3 centimeter will become 20 centimeter. It doesn't happen that way. But yes, there'll be some change in the fibroid. Some degenerations can take place sometimes. But I find many of them actually go very well up to term and deliver. And many deliver normally as well. And I can give you incidents of one patient who actually came with multiple fibroids. And she had a large uterus. My first reaction was, okay, so many fibroids, you're planning to conceive. Let me do your myomectomy, remove the fibroids, give you a little rest, and then you conceive. Next month, she came pregnant. We had no option. I said, okay, we'll follow you. We followed her 9 months. She delivered normally.
Okay.
Went back. Then we said, okay, this time in 3 months, you please come. We'll remove their very large fibroid. 6 months later, she's pregnant again. And then she comes and says, I'm pregnant again. I said, fine, let us deliver you again. We delivered again normally.
Okay.
So these fibroids were big, but they were toward the outside of the uterus, as I was saying.
Okay.
So you see, like you don't know.
It totally depends.
Yeah, so we don't have the final answer right now that which patient with fibroid will have difficulty or which may not. We can guess.
Okay.
We can have some clinical assessment. We guide them that way, but we are not gods.
Yeah. Uterine fibroids. They'll have a large bladder, pain in the back because of huge fibroids.
Yes.
How true is it?
It's very true. So large fibroids can, so in a body, if you know this is the uterus, we have the urine bladder in front and the rectum behind, right? So if the uterus gets towards anteriorly, it causes bladder problems.
Yeah.
So it can cause frequency, urgency, or all those things. But sometimes in the pelvis, the uterus can get retrograde.
Okay.
Retroverted. That means goes behind. It's the large fibroid. It goes behind. It goes and gets stuck in your pelvis, in the curve of your sacrum. And that time, it can actually cause urinary retention. So a lot of people don't understand. They say, oh, fibroid is in the posterior wall. It should cause that problem. But it's like a gravid uterus, you might have heard. The gravid uterus can also cause retroversion and urinary retention. And these patients actually need catheterization. Or a large fibroid can push on the rectum and cause chronic constipation.
Okay.
So, and pulling of those ligaments of the fibroid, the uterus, where the large fibroid resides, can give rise to lower back pain. So uterosacral ligaments from the uterus goes up to sacrum, right? So if there's a pull on that ligament, there will be sacral pain. There will be backache.
Okay.
And the feeling of heaviness in the pelvis, which is a very subtle sign.
Okay.
Women don't understand. They think, oh, I'm tired, I'm having backache, okay, tomorrow it will get over. But something else.
Okay. Let us discuss about early warning signs of uterine fibroids.
There are no early or late. There are some symptoms that women get. One is heavy menstrual bleeding. So if you have bleeding, which is more than your normal self, that means you are bleeding for more days.
Okay.
You are using more protection in terms of tampons or pads or menstrual cups, or you are passing clots. These all mean that there is heavier bleeding.
Okay.
And this requires medical attention. It's controlling your life. And fibroid could be one of the reasons. So heavy bleeding is one. Period pain is another. Not able to get pregnant is third. In general, lower back pain, heaviness in the pelvis, and a scan will very soon pick it up.
Is heavy bleeding only because of uterine fibroids?
No, heavy bleeding can occur for many other reasons. So in patients with fibroid, as I said, they can have a cousin adenomyosis. So the adenomyosis may be responsible for the heavy bleeding, not the fibroid alone. They can be together causing that problem. So heavy bleeding is a symptoms, and one of the causes is fibroid. But heavy bleeding can be because of endometriosis, could be because of adenomyosis, pelvic inflammatory disease. Even patients with having liver disorders can have heavy menstrual bleeding. Patients having coagulation disorders can have heavy menstrual bleeding. Okay. So there can be many reasons.
What is the difference between myomectomy and hysterectomy?
Great question. Okay, myomectomy simply means that we are removing the fibroids and saving the uterus. Okay. Hysterectomy means we are removing the uterus along with the fibroids. They are two different surgeries.
Yeah.
But today, and I'm going to come out with a concept which I have firmly believe and I offer it to my patients is, it's a woman's choice. It's not my choice anymore.
Okay.
So at no point will I tell my patient that, for you, I'm early to hysterectomy. I will not do myomectomy. It's a woman's choice at any age in life. So if the patient is young, of course, myomectomy is the choice by default. But supposing you are around 40, right? You have two fibroids. Who wants to not have periods at 40? Correct?
Definitely, yeah.
So why should I force that woman that you should have a hysterectomy? When technically I can do myomectomy. Even at 50, you may think that I should save my organ. And you have a right.
Yeah.
And I'm supposed to help you with that right. Because we understand that by and large, these fibroids are not cancerous. Only in some situations where I will say to a woman who has completed her childbearing that you undergo a hysterectomy other than myomectomy is if there are 20 fibroids. It doesn't make sense.
Okay.
Or if any of the fibroids in my scan or in my MRI gives me some suspicion that it could be some changes. Now, rarely what looks like fibroid can be cancer also.
Okay.
So let me not say that every time we talk about fibroid, there is no cancer. There can be, and that's a very aggressive cancer. So if there is any doubt of that nature, I will only guide that, although I give you that choice, but this is my suggestion.
Yeah.
And that's how I do. So I believe patients with fibroids have a choice to make. So this is out to all the women who have fibroids and are seeking treatment, especially surgery. Do not get under any pressure by your peers, your friends, or your family, or the doctor to have a hysterectomy when you did not want to lose your organ.
So how can we diagnose it?
Yeah. So once you are symptomatic or on a routine health check, the ultrasound is the simplest way to diagnose a fibroid and quite accurate as well. So ultrasound, pelvic ultrasound to check for uterus size and any kind of tumor there is the simplest way to diagnose. Once we have an ultrasound, if the patient, at least in my practice, if the patient is coming for a surgical management, then I would always like to do an MRI. The reason I would like to do an MRI in such patients is number one, that I accurately map those fibroids very well.
Okay.
Because if I have to remove the fibroids and save the uterus, I need to know what is my GPS, where are my fibroids, how do I do it. The second, it can also differentiate the fibroids from the slight changed fibroid that I spoke about, the sarcoma or kind of cancerous changes. The third is fibroids, as I said, there's a cousin hanging there in 30% patients, adenomyosis. So if I find adenomyotic features, I counsel the patient that I remove your fibroids, but all the bleeding problem may not get solved. Okay. So the cousin is hanging there. So counseling will help me. And the patients also come with realistic expectation. Otherwise, we may remove the fibroid and she continues to bleed heavily. She says, I had a fibroid surgery, but I still bleed. I should have had the information. So these are the two most important imaging tests that we do to diagnose fibroids.
So MRI is not for everyone?
Not for everybody. Initial diagnosis is just simple scan, and we follow patients with scan. I feel only when I'm doing a surgical management, I like to do an MRI.
Okay. So how often one should get check done? I mean this diagnosis and when they know they have fibroids and
once a year.
Okay, that's it.
Yeah. Because we know that's a slow growing tumor. Doesn't grow more than 1 to 2 centimeters every year. May even remain static. But there's no point doing every 3 weeks or every 4 weeks and getting more excited what is happening. Leave it.
So what are the advancements in treating?
So treatment we now are kind of also accepting that there is medication that can help in fibroid. What do we do with these medications? Are we able to make the fibroid disappear? No.
Okay, medically treated you cannot?
No, we can't make them
not even the sizes?
We can't make them disappear. So let me start like that.
Okay.
Because this is the common question patients ask. So I don't think that at the moment the medications that we have, I can make the fibroids disappear.
Okay.
But I can control your symptoms quite well. I can kind of reduce the volume of the fibroid a little. So if there is a, say, 5 centimeter size fibroid, which is giving you heavy bleeding, you don't want a surgery. Today we have newer medications that have come. It was being used abroad for quite some time. They are called GnRH antagonists.
Okay.
They are tablets. We had injections similar to that before, but we have tablets now, which is now coming to the market. And we can give that tablet, which 30 to 40% reduction in blood loss is definitely there. So if you're having heavy bleeding, that will control. Okay. So we can actually help you build up your hemoglobin levels. It can also shrink the fibroid a little. So 5 centimeter, if it becomes 3.5 centimeters, stops giving you symptom, we can watch you. But may not be effective for a 20 centimeter fibroid.
Okay.
But we are still advancing in medical therapy. Then we can have some non-invasive surgical management where we don't really do surgery, but we use the help of MRI or ultrasound to identify the fibroids and try and kill them by either heat or
Hmm.
ultrasound or something like
To
that.
make them shrink.
To make them shrink. So
Hmm.
there is MR, HIFU,
Hmm.
there is microwave ablation,
Hmm.
there is uterine artery embolization. So all those things are there,
Hmm.
clinically approved, being done,
Hmm.
but we really need long-term data.
Okay.
Some of them have long-term data like uterine artery embolization.
Hmm.
It cuts off the blood supply.
Hmm.
So anything, if you want to kill, you don't give blood, it will kill.
Hmm.
So it kills, it reduces the size, but it can have a very potential side effect of ovarian failure.
Okay.
Okay, because you are actually killing the blood supply
Yeah,
to the
yeah.
uterus.
Huh.
Same supply also goes to the ovary,
Hmm.
and it can cause ovarian dysfunction and even failure.
Hmm.
So it is at the moment still not recommended
Hmm.
in young girls who are still
Okay.
planning pregnancy.
Hmm. Hmm.
Right?
Hmm.
It's recommended for little older women
Hmm.
who have completed their family, but still an ovarian failure at 35 is never a good idea.
True.
So we have to be careful what we choose and counsel the patients well.
Hmm.
We also need to follow these patients and see, because some of the studies have shown that about 20 to 25% of these patients ultimately come back for surgery also, but they didn't respond.
Okay.
So we have to counsel these patients very well, but
Hmm.
options are there.
Hmm.
Then we come to surgery.
Hmm.
In surgery, you already asked whether we do myomectomy or hysterectomy. That's the only two things we
Hmm.
can do. We can do it, the method can be different.
Okay.
So starting from doing open surgery,
Hmm.
so as I told you in my 30 years of practice, I've started from doing open surgery to moving into laparoscopic surgery and now
And
robotic
robotic.
surgery. So all these advancements are patient friendly, of course,
Hmm.
because there are small holes and you feel you never had a surgery, there's
Hmm.
no pain, not much blood loss, and you can go home the same evening or next day.
Hmm.
But I have a different take.
Okay.
All these advancement and technologies are giving this benefit to you because it is helping me operate better.
Hmm.
Right?
Yeah.
So if I look at what open today, if I have to do an open surgery, I will get bukhar.
Hmm.
I said, oh my God, what am I going to do? But it's very rare. Maybe once a
Yeah.
year I might do
Hmm.
that, but in a particular
Hmm.
situation which demands that.
Hmm.
But and you can see those patients with a large scar and
Yeah.
they're like this for 3 weeks and 4 weeks, and I don't like it. Then we move to laparoscopic surgery. But if you look at how laparoscopy surgery works and how robotic surgery works,
Hmm.
there is a lot of difference in the technology.
Hmm.
The technology mainly, as a surgeon, gives me a different vision.
Hmm.
It gives me a better control of my surgical field. It gives me wrists,
Yeah.
right? It takes away my tremors.
Hmm.
It motion scales my movement.
Hmm.
That's a very important technological advancement we must understand. When we move our hand, we can't move less than 1 centimeter,
Okay.
right?
Hmm.
I mean, whatever
Yeah,
movement you
generally,
can, 1 millimeter you can't move, na?
no.
But if I doing the same movement for
Hmm.
my patient,
Hmm.
I can scale it down 10:1.
Oh.
So if I move 1 centimeter, my fingers,
Hmm.
it'll move only 1 millimeter inside you.
Hmm.
How precise I will
True.
be, right?
Yeah.
That's why we have less pain,
Hmm.
less
Hmm.
inflammation,
Hmm.
less blood loss.
Yeah.
So I believe that as a surgeon, I can do much better.
Hmm. Hmm.
And
With
that,
3D vision and all.
and there we are. Yes,
Yeah.
3D immersive vision is of course there,
Hmm.
that can help. So there are many advantages.
Hmm.
We are getting there. We have many more platforms.
Hmm.
Cost is coming down. More and more surgeons. And as I said, I founded and I'm the current president for the Association of Gynecological Robotic Surgeons of
Great.
this country. We have done huge, tremendous job in training. Many of the other gynecological surgeons in the city have been trained by me,
Yeah.
so, and many across the country.
Okay.
So we are trying to pass the skill
Hmm. Hmm.
and upgrade many gynecologists in doing it.
Happy to hear this.
In fact, you'll be also happy to hear that now, being the president for the Asian Society of
Wow.
Gynecologic Surgeons, I'm doing this across Asia.
Oh.
So it has been my real privilege and pleasure to actually go into the operating rooms in Philippines, in Manila,
Hmm.
in Kuala Lumpur, to help surgeons there to learn how to do robotic surgery.
Glad. We are so glad. Proud of you. Menopausal stage. How
Sure.
patients, how do they face up fibroids in their menopause stage?
So if woman has a fibroid and it was not operated,
Hmm.
it's going to stay. A lot of patients have the myth that you get menopause, it'll shrink.
Hmm.
Well, the logic is correct
Okay.
because what fuels the fibroid is your estrogen,
Hmm.
progesterone.
Hmm.
So we expect that when these hormones go down,
Hmm.
there will be reduction in the fibroid. And happens.
Some size.
It happens.
Hmm.
But again, it doesn't disappear. Okay. So an average size of fibroid will reduce a little and is hanging there.
Hmm.
I don't think we need to do anything, but we need to monitor it.
Hmm.
Two things. One, to see whether the size is increasing or
Hmm.
not. or the vascularity is increasing or not.
Mm-hmm.
Both of them could be a sign that there could be some change which requires.
Okay.
Sometimes, as I mentioned, if the fibroid is towards the inside,
Hmm.
they can cause postmenopausal bleeding.
Mm-hmm.
And when they cause postmenopausal bleeding, any postmenopausal bleeding, we are always worried we are dealing with an endometrial cancer or not.
Mm-hmm.
So we need to investigate.
Yeah.
So those patients require a hysteroscopy
Mm-hmm.
and some evaluation. Comes
Okay.
out to be benign, we don't do anything.
Mm-hmm.
We just leave them alone.
So we'll have our myths or facts round.
Sure.
Fibroids always turn into cancer.
Not true. Most often they are not cancerous.
Mm-hmm. Hysterectomy is the only solution.
Not true. It's a woman's choice.
Hmm.
Both hysterectomy and myomectomy are technically feasible and should be offered to the patients.
Okay. Fibroids disappear automatically after menopause.
They don't completely disappear. They may shrink and the symptoms disappear because the main symptom is heavy menstrual bleeding. With menopause, the bleeding stops. And that's why women are comfortable.
Can diet or exercise help them manage these fibroids?
Yes, good you brought this up. See, you have to understand that our hormones are fueling the fibroid. Our ovary is not the only organ that's producing the hormones. Our fat cells are producing the hormones too.
Yeah.
So if you reduce your fat cells, do regular exercise, eat well, and you reduce the amount of estrogen and progesterone in your body. And that's how you can help fibroid not grow very much.
One symptom women should never ignore.
Heavy bleeding. Because heavy bleeding is a sign that you are supposed to take care of yourself. This silently creeps up to cause anemia. It is not uncommon today that once or twice in a month I get patients with 5 and 6 grams hemoglobin.
Okay.
From good families. It's not that we think that somebody, lower socioeconomic patients will have good families, 5 or 6. It slowly creeped up, they never realized.
Okay.
So I think you should pay attention if you are bleeding more, as I said, using more protection or passing clots. Make sure you check your hemoglobin and don't be ignorant that you can get anemia.
Is it again this hereditary or a genetical fibroid?
Fibroid, yes. There is a genetic link that we have found. If your mother or sister has fibroid, there's higher chances that you might get.
Okay. One biggest mistake women make regarding fibroids.
When they are big, they keep thinking it will disappear or keep postponing. So if a symptomatic large fibroid is there, please seek treatment. Don't come to me when it becomes really big. It's very difficult to handle those patients. Because, see, if you treat a disease when it is not so advanced, we can treat better. You bring a complicated problem, I will treat, but it is difficult.
Yeah. It doesn't, you cannot give chances.
True. So don't ignore fibroids till your hemoglobin comes to 5 or 6 because it takes a long time for me to then build up your hemoglobin and then do a surgery or something. So keep an eye on it if you have a fibroid. 2 things you have to keep an eye on it. One is your hemoglobin level and the other is the size of the fibroid, what's happening.
Okay.
So do both hemoglobin test and ultrasound maybe 6 months or 1 year apart.
Okay. One message you would like to give to women who are listening to a podcast?
Well, women, take care of yourself. And since we are talking on the topic of fibroid, the commonest symptoms, as I said, is heavy menstrual bleeding. So if there is heavy menstrual bleeding, which is now controlling your life, it needs or it deserves medical attention. So don't ignore it. The second is a very subtle symptom is of fatigue. You may be superwoman, juggling many things. But I think at 6 or 6:30 or 7 o'clock in the evening, you are just don't want to talk to anybody. Or maybe you snapped on somebody. Yeah. Or your children did not do your homework, so you got really angry. That's the time when you must look into what's wrong with me. Okay. And it could be just anemia. Also remember that if you do a hemoglobin, it might be okay. It might be 10 and you said, okay, I'm fine.
Yeah.
But do your iron levels and you'll find they are so low and that is the reason for fatigue.
Okay.
So don't ignore this subtle symptom as well.
Thank you so much, ma'am, for your time and your sharing your knowledge with us and for your great insights also. Thank you so much.
Thank you, Mansa. Always love to be with you.
Thank you.
And you ask lovely questions and this is a very, very lovely podcast. Thank you for having me.
Thank you, ma'am.